A 67-year-old man presents with acute onset word-finding difficulties and mild weakness in the right arm, which lasts 5 minutes. His blood pressure is 149/89. He has a history of diabetes mellitus and hyperlipidemia. Which of the following is his ABCD2 score? So this is a predictor for TIA that predicts risk of future stroke and is used to determine who should be admitted to the hospital and who can be safely discharged home. So one is age greater than 60. I believe it's like blood pressure greater than 160, so he does not meet that. And then diabetes is 1. And then duration of symptoms and nature of the symptoms. So he has weakness lasting 5 minutes. So it's 1 point for weakness or speech difficulty and 1 point for, but it doesn't last 10 minutes. So that would be 3. And I think maybe the blood pressure does meet the cutoff. So probably it's 4. Oh wait, he had both weakness and speech difficulty. That's 2. So I think 4. And I'm not sure if he meets it for blood pressure. I don't remember the cutoff off the top of my head. So I believe it's C or D. Normally the cutoff is 4 to be admitted to the hospital, so it wouldn't really matter. I'm going to say it's 5. Let's see. Yeah, it's 5. So blood pressure, clinical symptoms, duration of symptoms, diabetes. Okay. All right, so I guess the blood pressure met the cutoff there. A 67-year-old man presents with an acute onset of word-finding difficulties with mild weakness in the right arm. His NIH stroke scale is 3. His blood pressure is 149/89. He has a history of atrial fibrillation, diabetes mellitus, and hyperlipidemia. Which of the following factors would be considered a contraindication to the administration of IV TPA? Blood pressure 180/100 would be completely fine. Gastrointestinal bleeding 1 year ago, it depends what it is, but that could be an issue if it's untreated. Mild symptoms along with his current NIH stroke scale. I think I would still give it if he had a bad deficit in his arm. They say mild weakness. That's a relative contraindication. Treatment with direct oral anticoagulant with last dose 24 hours prior. You could still reverse it and give it. A small, less than 10 millimeters unruptured aneurysm. That's definitely not a contraindication. Bleeding within 3 weeks would be considered a definite contraindication. There's no specific listed contraindication from the NINS trial, and whereas mild symptoms was a direct contraindication. And in many cases, you can still give IV TPA if someone is taking a DOAC. So I believe the right answer is C, and they say no with direct oral anticoagulant within 48 hours, contraindication. But a lot of the times you can reverse it. I was a little bit confused by that one. And I guess they don't say anything. Current guidelines and available clinical trial data support the use of TBA even for mild symptoms. Yeah, I mean, it depends on the deficit. If it's extremely mild, I wouldn't give it. But, okay, a 67-year-old man is transported to the hospital after cardiac arrest. He is intubated en route and admitted to the neurocritical care unit where a hypothermia protocol is initiated. So often after someone has a cardiac arrest, there's evidence that lowering body temperature may reduce the risk of neurological injury. In this situation, which of the following is a reliable predictor of poor neurologic outcome at 3 days? So absent pupillary light reflex, yes, that is part of it. Age, I don't think is really a big criteria. Flexor posturing on motor exam. Neuron-specific enolace greater than 33. I believe there's specific evidence of this. Presence of N20 on median nerve somatosensory evoked potential. It would be actually the absence of N20 that would be concerning. So I believe neuron-specific enolace. I don't remember the cutoff, but I think the examination findings are not as specific. And that's not correct. Absent pupillary light reflex is a reliably poor predictor. Okay, neuron-specific enolace levels have a high sensitivity, but also a significant false positive rate. Interesting. Okay, so tricky. Okay, 1 week after experiencing a ruptured aneurysm, a patient reports increasing headaches and a new onset pronator drift of the upper extremity. Transcranial Doppler velocities in the middle cerebral artery are greater than 200 centimeters per second. Which is the most likely diagnosis? Okay, so basically they're saying he has high velocity, so he probably does not have vasospasm. So B is probably wrong. Enlargement of the aneurysm would be impossible to know. It's probably more likely a rebleeding since he has new headaches, and that typically occurs like within the first 48 hours, though. Okay, hydrocephalus usually would not cause like such focal symptoms. I'm not sure how you would judge enlargement of the aneurysm. I would guess rebleeding or edema, although I think they're going to say rebleeding usually wouldn't occur this late, so maybe it would be edema. I'm going to say it's A or E, probably E, just because rebleeding doesn't occur so long, a whole week afterwards. Let's see if that's right. No, vasospasm. Interesting, even though the Doppler velocities are high. Although hydrocephalus edema or rebleeding may be associated with some degree of worsening after subarachnoid hemorrhage, vasospasm peaks about 10 days after the event. The best indication of vasospasm is worsening condition, increased velocities on transcranial Doppler. Oh, I see. I completely misread that. You get increased with vasospasm. You get increased velocities because the caliber of the arteries is narrower. I just botched that one. Okay, a 72-year-old man was recently discharged from a rehabilitation facility where he was treated following a stroke. He can now ambulate without assistance and communicates effectively. However, his wife states that since he has been home, he stays in bed or watches television and is not interested in going out or participating in his hobbies. Depression is suspected. Which of the following statements about depression following stroke is true? Deep ganglionic structures are not associated with post-stroke depression. It's more associated with like left frontal injuries, but it's hard to say that they're not associated. Incidence peaks 2 weeks after the ischemic event. I'm not sure about that. Major or minor depression occurs in approximately 10% of patients following strokes. It's probably even more than that. Patients with anosognosia are not at risk for post-stroke depression. That's probably not true. Selective serotonin reuptake inhibitors are indicated for patients with suspected post-stroke depression. Yeah, there's definitely evidence of that, so I will go with that. And that is correct. Okay. A 20-year-old woman presents with acute onset weakness in the right arm and expressive aphasia. Examination reveals a temperature of 37.5, a little bit high, but no apparent skin rash, cardiac murmur, or apparent joint swelling. Her MRI scan shows abnormalities consistent with acute ischemia, a segment in the left middle cerebral artery. Which of the following infectious agents, which is most likely responsible for her condition? CMV, it doesn't typically cause endocarditis. Echovirus, I'm not sure. Mycoplasma, parvovirus, varicella. Interesting. No rash, murmur, or joint swelling. So I'm not sure what they're getting at here. Is there a virus linked to stroke that does not cause these other symptoms? Well, I know varicella can cause a vasculitis. That may be what they're going at. Can any of these other agents cause a CNS vasculitis? I'm really not sure. I guess a parvovirus, I'm not sure, can cause this syndrome at all. It can cause aplastic anemia. Mycoplasma can cause cardiac disease, should be associated with cardiac murmur. Echovirus can cause heart failure. CMV can cause heart failure, but there's no murmur. I'm going to guess they're saying it's like a varicella vasculitis. She's young, has fever. I'm not sure about this one, though. I did guess right, though. Okay, so has been associated with stroke. Okay, so a lot of people don't have rash they're getting at. Okay, tricky. A 72-year-old man who presents with an 8-month history of forgetfulness and decreased attention span has a history of hypertension, but not stroke. His mini-mental status exam score is 21 over 30, so low. Examination reveals normal use of language and normal strength, but mild increased tone bilaterally and gait apraxia. Increased tone and gait apraxia. Okay. Which of the following statements is true? So this person could have normal pressure hydrocephalus, possibly. Okay. History of hypertension does not impact cognition. Okay. It could impact cognition because it can lead to vascular dementia. The probability that silent ischemic infarctions will develop is 5%. It's probably much greater than that. The risk of dementia is twice that among individuals with evidence of stroke on imaging studies. That doesn't make sense. The risk should be higher in people who have stroke on imaging studies. The risk of dementia with stroke is the same regardless of patient age. I don't think that's true. Age is a big factor. The risk of dementia is greater with stroke in the posterior fossa than the cerebral hemispheres. That doesn't make any sense. So none of these answers make any sense. Sorry, this one is correct. The risk of dementia is greater in people who have evidence of stroke. That makes sense. There we go. Okay, I misread that at first. Which of the following statements best describes constraint-induced movement therapy following stroke? So this is where you like tie the healthy hand up so they have to use the paretic hand. This therapy can be used only in patients with chronic motor deficits. I don't believe that's true. Sensory inhibition in the damaged hemisphere occurs with this therapy. I don't think that's true. Clinical improvement is seen, but cortical function as measured by functional MRI remains unchanged. I don't think that's true. This therapy is effective regardless of the extent of the deficit. I'm not sure about that. This therapy is most effective in patients with mild or moderate deficits. That makes sense. Probably it's not going to be as effective if there's a very severe deficit. I'm going to guess E, and that is correct. That was just based on logic. A 60-year-old woman with a history of prosthetic valve in the mitral position presents one day after sudden onset inability to walk with a tendency to lean left with standing with assistance. Severe dysarthria, moderate occipital headache, and occasional vomiting. Examination reveals left-sided cerebellar ataxia, truncal ataxia, dysarthria, and bilateral direction-changing horizontal nystagmus. So it suggests that it's like a cerebellar lesion, likely on the left side. Her MRI scan has shown which of the following is the vascular distribution of the acute infarct. So it is, in fact, a left cerebellar infarct, and this looks like probably left anterior inferior cerebellar artery. I'm guessing, most likely. Or it could be the superior cerebellar artery. Well, often people get like hearing problems and things like that, but not necessarily. Okay. So it's not pica. I don't believe it's pica. Usually you get hearing loss with ICA, at least classically. I think probably... It's like the cerebellar hemisphere. No hearing loss. I'm going to guess SCA. I'm not really sure about that. It's very medial, though. It doesn't look like what I've seen with SCA. Okay, I'll stick with my intuition. I'm not sure about this one. Yeah, SCA. Okay. Left-sided cerebellar infarct and the superior cerebellar distribution. I guess they were going like no hearing loss, no brainstem involvement. Okay. Which of the following substances causes vasoconstriction by blocking reuptake of norepinephrine at the synaptic nerve endings? So this would be, I believe, cocaine is the answer there. The others have a different mechanism. Marijuana doesn't cause vasoconstriction. Yeah, that's correct. Okay. A 59-year-old man was admitted to a neurorehabilitation unit 1 week ago following a stroke, has shown few signs of recovery. Which of the following is most likely to improve his motor recovery? An anticonvulsant, very unlikely. Clopidogrel obviously wouldn't affect motor recovery. This is Plavix, a blood-thinning agent. Electroconvulsive therapy, this could be used for depression. HMG-CoA reductase inhibition at the time of index stroke, it wouldn't really affect recovery. Probably SSRI, if he has depression, would be the most likely. That has the best evidence, assuming he has depression. That's what they were getting at. Okay. Motor recovery improves because of treatment of depression. A 42-year-old woman is admitted for headache and intermittent paraparesis. Cranial MRI scan shows a superior sagittal sinus thrombosis. Which of the following tests is the least useful in establishing the cause of an underlying hematologic problem? Okay, so PTT and ProTime. Lupus anticoagulant is certainly reasonable. CBC. Protein C retesting after resolution of the thrombosis. Protein C testing on admission. I think both D and E are very reasonable. Protein C testing on admission is probably not very useful because it's often abnormal. Of course, you would do a CBC and ProTime and PTT. That makes perfect sense. So I'm going to say testing on admission is not very useful. And that is what they were getting at. It's going to be falsely abnormal. A 60-year-old man has a history of coronary artery disease, atrial fibrillation, hypertension, and congestive heart failure. He's neurologically asymptomatic, does not have diabetes mellitus, and he's never had a stroke or TIA. His serum creatinine is 0.8, which is normal. Based on his CHADS-VASc score, which of the following is the most appropriate intervention to decrease the risk of thromboembolic events? So he has hypertension and CHF, and he doesn't have diabetes, but it's going to be warfarin. not double antiplatelet. So a DOAC, some kind of anticoagulation. So there's no such thing as fixed dose warfarin. He would be higher risk. I don't know the exact score off the top of my head, and that is correct. What do they say about fixed dose warfarin? Adjusted dose warfarin. Yeah, fixed dose warfarin is a weird thing to say. A 52-year-old woman presents with acute onset headache and right-sided hemiparesis. Her CT scan shows a hemorrhage in the left thalamus and internal capsule. Her blood pressure is 200 over 120. Which of the following agents is most likely to quickly control and titrate the patient's blood pressure? So IV hydralazine is definitely pretty fast. IV labetalol is also fast. Enalapril wouldn't be used. Nifedipine wouldn't be used. IV nicardipine would be most commonly used for acute treatment of hypertension. Okay, I believe this is the correct answer. Yeah, there we go. Which of the following disorders related to ischemic stroke results from the deficient activity of the enzyme alpha-galactosidase A? So I believe this is Fabry's disease. I see a lot of Fabry's disease patients, so that's an easy one for me. A 75-year-old man being treated for hypertension presents with sudden onset headache and left-sided hemiparesis. Examination reveals an NIH stroke scale 7 and a blood pressure of 170 over 85. His head CT and gradient echo brain MRI scans are shown. Which of the following is the most likely mechanism of the intracerebral hemorrhage? So he has hypertension, but let's take a look at the scan. So it looks like, there are a lot of GRE lesions, so he may have amyloid angiopathy, and this is very lobar, not typical of hypertension. He does have some hypertensive changes in the pons. Probably they're going at the amyloid angiopathy, though. So, yeah, I'm going to guess amyloid angiopathy just based on the, he's treated for hypertension, so, yeah. Yeah, that's what they were going for. Those tiny little hemorrhages, the GRE dark lesions throughout the brain, are typical of amyloid angiopathy. A 28-year-old woman presents with new symptoms of slurred speech and weakness in the right arm and right leg. The patient takes oral contraceptives. Which of the following is most likely to be an associated risk factor in this patient? So atherosclerotic carotid stenosis would be very unlikely in a 28-year-old. Factor V Leiden, certainly, although it's not really strongly associated with stroke, it's more associated with venous clots. Migraine with aura, that's known to increase the risk of stroke in people taking oral contraceptives, so that's probably the answer. Cardiomyopathy, there's nothing specific to suggest that. And protein C deficiency, again, more associated with venous clots. So this is kind of a known thing. Migraine with aura is a contraindication to the use of estrogen products. Not very well known, actually, but it is important. A 76-year-old man who is being treated for dementia has a long-standing history of hypertension that has never been well controlled. He and his wife deny any significant change in his gait or urinary incontinence. Which of the following neuroimaging findings is most likely to indicate a diagnosis of vascular dementia? Okay, in other words, dementia related to small infarcts. Evidence of a single chronic thalamic hemorrhage? No, that would be very atypical. An embolic appearing infarct in the cerebellar hemisphere? No. Presence of hydrocephalus? That has nothing to do with vascular dementia. Parietal lobe atrophy? No. And of course, this is a simple one, multiple silent subcortical infarcts. That's just the definition of vascular dementia. A 65-year-old woman with hypertension, hypercholesterolemia, and a history of stroke is being treated with clopidogrel, or Plavix. She is admitted with abdominal pain and found to have upper gastrointestinal bleeding. Which of the following is the most appropriate intervention? Folic acid, B6, and vitamin B12 has nothing to do with this. Lipid-lowering therapy with statins has nothing to do with this. Omega-3 fatty acids. Okay, prophylactic use of proton pump inhibitors, that makes sense because it's likely that she has some kind of ulcer or something like that. So generally proton pump inhibitor. Nothing else will really help her acutely. So that's just whatever is going to help her acutely. Anticoagulation is indicated for which of the following cardiac conditions associated with embolic stroke? So atrial myxoma, I'm not sure about that. This is a cardiac tumor. I'm not sure about the exact recommendations for anticoagulation. So anticoagulation is contraindicated in a bacterial infection of the heart valve or bacterial endocarditis. Mitral valve prolapse, no, that's very common. Patent frame or ovale, I think there's a little unclear data on this, but it's not specifically recommended. rheumatic mitral valve disease. So probably it's A or E. I honestly don't know the answer to this. I want to say it's not routinely used in atrial myxoma, but maybe it is routinely used in rheumatic mitral valve disease. The rest do not make sense, so I think I'm going to guess E, and I did guess right. Okay, it's contraindicated in atrial myxoma. I did not know that. Okay, that's good to know. A 50-year-old man presents with a 3-hour history of acute right-sided head and face pain and left-sided waxing and waning weakness in the arm and face more than the leg. His angiogram is shown. Which of the following is the most likely diagnosis? So, head and face pain, left-sided weakness. Okay, this is a little tricky. So this is the common carotid artery. Oh, this is the external carotid artery, I believe. And this is the common carotid artery showing like a tapering. So this is mostly likely a dissection. You see this tapering edge here. It's a little tricky because I'm not used to looking at images of like the external carotid artery. So this is a common carotid artery injection. And it says a 50-year-old man, so he's relatively young. So I'm going to say it's a carotid dissection. I'm not sure how you would diagnose a blowout. It doesn't look like fibromuscular dysplasia. It doesn't really look embolic because it's kind of like this sharpened edge, nor does it look like atherosclerosis. And I am right there. Okay. A 60-year-old woman who presents with evaluation after a transient ischemic attack has a history of diabetes mellitus and hypertension. Her neurologic exam is normal, and her vascular and cardiac workup is negative. Along with antiplatelets and medication for diabetes control, which of the following medication classes is recommended for secondary stroke prevention in this patient? Okay, TIA, diabetes, hypertension. Okay, so she's already getting antiplatelets. So it's going to be... Okay, so fibrates, not specifically ACE inhibitors. So it says, so basically for hypertensive control. It doesn't say that she has high blood pressure, so I'm not sure what the basis of that would be. Niacin does not reduce the risk of stroke. Nitrates, no. Thiazide diuretics. I believe the best evidence is for ACE inhibitors in prevention of stroke rather than diuretics. And yeah, that's correct. So while blood pressure is a primary goal, a specific group of medications might be more useful, such as ACE inhibitors. Yeah, I have heard that before. In patients with favorable Glasgow outcome score 4 to 5, what is the prevalence of cognitive and social impairments 1 year after subarachnoid hemorrhage? I have no idea, but presumably it's going to be a pretty low number because they have a favorable outcome score. I'm not really familiar with the scoring. I'll guess... the prevalence is low, like less than 20%. But it could, maybe they're going for higher. Less than 20%, less than 5% is certainly wrong because it could also be less than 20. I'm going to guess it's still fairly high that they're going for. It's higher than you think it is, even with the favorable score. Because subarachnoid hemorrhage can be pretty bad. Yeah, I guessed right there. I didn't really know that. So basically they're getting at subarachnoid hemorrhage is pretty severe even if they have a good outcome score. Okay, which of the following statements about septic cavernous sinus thrombophlebitis is true? Okay. A CSF analysis usually shows a lymphocytic pleocytosis. Not sure about that. So septic would be associated with bacterial infections in most cases, so it should be neutrophilic. CSF analysis usually shows polymorphonucleocyte pleocytosis, so that makes sense. Engorgement of the ophthalmic veins leads to proptosis and chemosis. That could definitely be true. Okay, definitely could be true. Infection usually is a result of extension from the mastoid air cells. I'm not sure about that, but more usually you would get like a transverse sinus thrombosis from mastoiditis, so that's probably not correct. Vision loss due to optic neuropathy is uncommon. I think you can get vision loss, so probably the answer is B or E, and it's kind of well known that a cavernous sinus lesion you can get engorgement of the ophthalmic veins and proptosis and chemosis. I'm not really sure about CSF findings, so I'll just go ahead and guess C. There we go. Okay, venous congestion. Yeah, I was most sure about that one. Okay, a 72-year-old woman with a history of atrial fibrillation, stroke, diabetes mellitus, hypertension, and hyperlipidemia experienced one transient episode of right-sided weakness and aphasia 1 month ago. She takes antihypertensive and lipid-lowering therapy as well as aspirin after her primary care physician discontinued warfarin following a fall 1 year ago. She had given a risk of falls and a CHADS VAS score of 6, what is the most appropriate medical therapy to prevent future ischemic stroke? So what they're getting at is, generally speaking, the benefit in preventing stroke with anticoagulation is likely greater than the risk of having a serious bleeding event with falls. So usually we would give anticoagulation, such as with warfarin. There's no specific reason to give both aspirin and warfarin. So I think D is correct, yeah. And that's what they're getting at, that falls are sort of outweighed by risk of stroke. A 72-year-old woman with a history of atrial fibrillation, stroke, diabetes mellitus, hypertension, and hyperlipidemia experienced one transient episode of right-sided weakness and aphasia 1 month ago. She takes antihypertensive and lipid-lowering therapy as well as aspirin. After a primary care physician discontinued because of non-compliance with warfarin following a fall 1 to 2 years ago, very similar to the last question, which of the following is her estimated annual risk of stroke on aspirin? So I'm just using the original CHADS 2 score because I know the numbers. So history of stroke is 2, diabetes 1, hypertension is 2, hyperlipidemia, and age, so 5. So I believe it's like around 12% or something. So it's probably 10 or 15%. See, I don't know the exact numbers for the new CHADS VAS score, but I believe it's 10 or 15%. So it's pretty high. She basically should be on anticoagulation. I'll guess D. It may be C here. It was C. Okay. According to her CHADS VAS score, the patient's annual estimated stroke risk on aspirin is 9.7%. So I'm a bit behind the times. Which of the following clinical findings is more common in children with moya-moya disease? Dystonia, intracerebral hemorrhage, ischemic cerebrovascular events, optic disc abnormalities, subarachnoid hemorrhage. So these children are at increased risk of strokes. Yeah. Moya-moya disease is this disease where you get constriction of the blood vessels in the brain. You get these tiny little moya-moya vessels that are sort of compensatory vessels. A 16-month-old infant presents with 2 hours after experiencing a right-sided focal motor seizure. He has been somnolent and has not moved his right arm and leg since the seizure. The parents report the patient fell 12 inches from a sofa onto a carpeted floor 1 hour prior to the seizure but did not lose consciousness. Examination reveals a port wine birthmark involving the left upper eyelid on the forehead. MRI scan of the brain is most likely to reveal which of the following findings. So this child likely has SturgeWeber syndrome, which is a regional syndrome. And you can get this like tram track type sign. Let's see what arteriovenous malformation of the left frontal region, cerebral contusion. But this is a fall, from a small height onto carpet, so that's unlikely. Leptomeningeal vascular malformation of the left posterior region. This is the finding of SturgeWeber syndrome. Multiple cavernous malformations, that's a different disorder. Subdural hematoma. Again, this is a fall onto carpet, very unlikely to cause this. So yeah, they're getting at SturgeWeber syndrome.